People is Dr. Shrihari. He is a well-known gastroenterologist from the Sir Gangaram Hospital, Delhi. He has keen interest in advanced endoscopy, NBI, and motility, and he has established a state-of-art motility lab in Gangaram Hospital. Over to you.
Could I have the slides, please? Yeah. So I'm extremely grateful to Dr. Nitesh Pratap and INMA for giving me this opportunity to present on this platform. I will be presenting on anorectal manometry, the procedure and metrics. When we talk of metrics, I would like to focus on the London classification, which is the latest classification for classifying anorectal disorders, which has been published recently. So when we talk of stool evacuation, the initial ab-oral movement of the fecus, the fecal material, is seen through other tests like a colonic transit study. What we see in an anorectal manometry is the last part. So when the stools come and they deposit in the rectum is a capacious reservoir. And when there is a deposition of stool in the rectum, there is a filling of the rectum and this generates rectal sensations. And eventually this leads to an urge to defecate. Now, after there is an urge to defecate, there is a rectal evacuation which occurs. And this evacuation occurs when there is a coordinated increase in the rectal pressure and a decrease in the anal sphincter pressure. So this fag end of the physiology of the rectal evacuation is what is seen through an anorectal manometry. An anorectal manometry is done with our conventional manometric techniques. These are the conventional water perfused manometry systems, or you could use a solid state catheter for doing the anorectal manometry. In an anorectal manometry, this is how the patient is positioned. The patient is in the left lateral position, and you can the catheter has been inserted, and this is our setup where we have two screens. One of the screens where the patient is able to see that screen, that is especially useful when you do biofeedback, because the patient is as much involved in the procedure as much as you are. And the other screen on the right is one which is used by the investigator. So the best part about anorectal manometry is it's a very, very simple technique. No fasting is needed. No sedation is needed. A colonic preparation, extensive colonic preparation is also not essential. Only an enema is sufficient. The position that is usually preferred is a left lateral position for an anorectal manometry. And when you're doing for a balloon expulsion test, that is where you prefer a seated position. One thing of importance I would like to emphasize here, when you use the lubricant, avoid using a lignocaine jelly, because you're testing for rectal sensations when you do an anorectal manometry, and this can alter the sensations. So a KY jelly or any other lubricant is much more preferred over a lignocaine jelly. Initially, before you do the manometry, obviously a digital rectal examination is mandatory to determine the presence of any possible abnormalities like stenosis, painful lesions or tumors or etc. So once you have set up the patient, how do you position the catheter? The catheter is positioned in such a way that the high resolution zone, so high resolution zone is, is there a marker here? So the high resolution zone of any catheter system is there where the sensors are closely placed. So in an anorectal manometry, your high resolution area should be at the anal sphincter. So how do you recognize the anal sphincter? The anal sphincter would be that area which is giving you a consistent high pressure zone. So your catheter is positioned in such a way that the high resolution zone is focusing on the anal sphincter. The lower resolution, the low pressure area at the top is the rectum, and the low pressure area at the bottom is the exterior. So once you have positioned the catheter, you do a series of sequence of tests. So now the London classification has tried to standardize these sequences, which was not there previously, just like a Chicago classification is doing it for esophageal manometry. So first is the state of stabilization for 3 minutes. Then you give the patient rest for 60 seconds so that the patient is accustomed to the machine. You do 3 short squeezes of 5 seconds each. There is a 30-second recovery period between these 3 short squeezes. Then there is an endurance squeeze for 30 seconds. again a 60-second recovery period, 2 cuff reflexes, then you do 3 push sequences, then you evaluate for recto-anal inhibitory reflex, then you check for the rectal sensations, and last you do is the balloon expulsion test. So resting anal pressure. So resting anal pressure is you are putting the catheter and just seeing what is the pressures at rest. So as we are all aware, the resting anal tone, most of it is determined by the internal anal sphincter, 60%. Some part of it is by the external and some part of it is by the hemorrhoidal cushions. The internal anal sphincter pressures or the sphincter pressures at rest are seen to be lower in women as compared to men. And with increasing age, the sphincter pressures go down. There have been some normative values. There is a recent publication by Dr. Deshmukh and his group in 2022 who has done this study on around 90 patients. This is the normative Indian values. We ideally should have a bigger series. That was what Professor Goshwal was talking about. And in his series, this was the normative values. And mind you that these values are different for different manometry systems. So you should be sure of which manometry system you are using, because every manometry system will be having a slight difference in the pressures that they use. Then comes to when you ask the patient, when there are certain patients in whom you can see high resting anal pressures. So this could be seen in patients with anal fissure or proctitis. And you could see patients having low anal pressures. This could be seen in patients with obstetric traumas, especially road traffic accidents, post-anorectal surgery, or elderly patients with comorbidities. Now the London classification has renamed them as anal hypertension. So patients who have high basal sphincter pressures are called anal hypertension, and those who have low sphincter pressures are called anal hypotension. Then you perform an anal squeeze where the patient is asked to squeeze to his maximum. So squeeze pressures in females are slightly lesser than men, and they are lesser in elderly as compared to younger people. So these are the normative values for the Indian subset of patients. There's no possible relevance of a high squeeze pressure, but yes, there is relevance for a low squeeze pressure. So patients with low sphincter squeeze pressures could be seen in patients with obstetric trauma, RTAs, post-anorectal surgery, elderly patients who have comorbidities or the history of sexual abuse. So low anal squeeze is now called anal hypocontractility. So this is the new term for a low anal squeeze. Then you do something called as a cuff reflex. So cuff reflex is basically a protective reflex. What is seen in this is that when the patient is asked to cuff, you can see the increased pressures in the rectum. So basically when the patient cuffs, the intra-abdominal pressure rises, and this actually translates to an increased intrarectal pressure. But corresponding to that is an increase in the pressure of the sphincters. So basically it's a protective reflex which prevents the abdominal contents passing out when the patient is cuffing or increasing his intra-abdominal pressures. So cuff reflex actually helps you in certain situations. So basically it helps you to check the integrity of the local reflex arc. The cuff reflex is mediated through the local sacral segments of the spinal cord. So normal cuff reflex with a normal squeeze pressure is a normal finding in patients. Especially in patients with fecal incontinence, this is where this helps you. In fecal incontinence, if there is an absent cuff reflex, there is possibly a defect in the sacral reflex arc. This could be seen in patients with sacral nerve injury or cauda equina syndrome. If you have, in a patient with fecal incontinence, if you have a normal cuff reflex with low squeeze pressures, possibly you're dealing with any defect in the central motor pathway above the sacral segments. Then comes an important reflex called recto-anal inhibitory reflex. So in this, what is done is that you inflate the balloon in the rectum. There is a balloon attached to the catheter. So when you inflate the balloon in the rectum, here you can see there is a slight increase in the rectal pressures. There is a drop in the sphincter pressures. So this is a normal recto-anal inhibitory reflex. So RAIR is present. It is a normal finding, and this virtually rules out Hirschsprung disease. If RAIR is absent, does not mean that this patient has Hirschsprung's, but there is a possibility that he might have Hirschsprung's. So if there is a complete lack of RAIR, this could mean Hirschsprung disease. This could mean Hirschsprung's disease. any variants of Hirschsprung. This could also be seen in patients who have undergone surgeries like an LAIR. If you cannot elicit RAIR at the standard volumes of distension, which is 50 cc for males and smaller distensions for children, like even 10 cc is enough, then you have to increase the distensions and you can go up to maybe 200, 300 ml. So up to 300 ml can be seen in megarectum, 200 ml in Chagas disease. And sometimes you see a rebound contraction after a RAIR. This could be seen in painful conditions like anal fissure or proctalgia. Now, a lack of RAIR, according to the London classification, is now labeled as recto-anal areflexia. This is important because from now on, you would be hearing about these terms more often than the previous terms. Then you come to rectal sensory testing. In this, what we do is we inflate the balloon in 10 to 20 ml of increments. This is either with air or water. You can do it in a ramp fashion, where you inflate, deflate, and again inflate it to the next volumes, or you can do it in a continuous fashion from 10 ml to 20 ml to 30 ml and so on. And 3 sensations are tested. That is the first constant sensation volume, the desire to defecate, and the maximal tolerated volume. And these are the normative values that have been quoted in the recent study for the Indian population. So in such cases, you can see rectal hypersensitivity, where the sensations are coming at much lower rates. This could be seen in conditions like proctitis. IBS is one situation where you can see a rectal hypersensitivity, because as we all know, IBS is associated with visceral hypersensitivity, and rectal hypersensitivity is one of indirect correlates for a visceral hypersensitivity. This could also be seen in urge fecal incontinence. Rectal hyposensitivity, on the other hand, is frequently seen in defecatory disorders, because usually there is a retention of stool which eventually leads to a distended rectum and possibly leads to a decrease in the mechanoreceptor and the sensory activity in the rectum, eventually leading to megarectum. Now, rectal hypersensitivity, according to the London classification, you need more than or equal to 1 sensory threshold. Among these 3 sensations, any one or more is abnormal. It is rectal hypersensitivity. But for rectal hyposensitivity, you have to have 2 or more sensory thresholds below the lower limit of normal. So this is the difference in the London classification. Then the most important part is something called simulated defecation. Here the patient is asked to bear down, and the most standardized technique is by using 50 ml of inflated balloon. We prefer water over air because it looks more physiological when you ask the patient to bear down. And this is a very crucial step to evaluate for dyssynergia, and it has shown to have some sensitivity and specificity of around 80%. So normally when the patient is asked to bear down, what you should ideally see is an increase in the intrarectal pressures and a simultaneous decrease in the anal sphincter pressures. So this is the normal physiology that should be seen when the patient evacuates. So this is what we expect normally, but you can see something like this. So the difference between this and this is, here the rectal pressures are rising and the sphincter pressures are falling down. But in this patient, when you ask the patient to bear down, his rectal pressures are increasing as compared to baseline a bit. But if you see sphincter pressures, they are even more increasing as compared to baseline. So this is a dyssynergic defecation. So there are 4 patterns of dyssynergia that have been mentioned in literature. Type 1 dyssynergia, where you have an adequate increase in the rectal pressure, but at the same time there is a paradoxical and simultaneous increase in the anal sphincter pressures. In type 2 dyssynergia, you have an inadequate increase in the rectal pressure. There is some increase, but it is inadequate. And at the same time, there is a paradoxical increase in the anal sphincter pressure. In type 3 dyssynergia, there is an adequate increase in the rectal pressure, but there is no relaxation. There's no squeezing, but there's no relaxation of the anal sphincter. And in type 4 dyssynergia, you have an inadequate increase in the anal rectal pressure, and you have a failed relaxation. So these are the 4 types of dyssynergia that have been quoted. So then comes the balloon expulsion test. So in the balloon expulsion test, the patient is asked to expel a 50 cc of inflated balloon, and usually a time of 1 to 3 minutes has been given. The most standardized literature says 1 minute. And the ideally to do this is that the patient sits on a commode, he's given privacy and he's given a stopwatch, and he's asked to evacuate this balloon. This balloon could be anything. It could even be a simple infant feeding tube where a balloon has been attached, or it could be a Foley's. You don't need elaborate manometry apparatus. But conventionally, when you are doing this anorectal manometry, in the same anorectal manometry setup, you can do this procedure. But because the patient is in left lateral position, you have to assist the evacuation of balloon many times. And some centers have advocated the use of a pulley with a certain weight, or you give a gentle traction to this catheter when the patient is asked to evacuate. This would, the upper part would be the ideal situation to do it. So there could be different subsets of possibilities when you do this in the London classification. I'll just take one more minute. So when you do a balloon expulsion and it is absent, and on the manometry you have a present contraction and the rectal generation is normal, but the patient has not been able to expel the balloon. So this is abnormal expulsion with dyssynergia. You have a patient where balloon expulsion was absent, the anal contraction was present, the rectal pressure generation was, however, abnormal. So this is called abnormal expulsion with poor propulsion. This is all in the latest classification. You have an absent balloon expulsion, the anal contraction is there, the rectal pressure generation was abnormal. This is abnormal expulsion with poor propulsion with dyssynergia. You could have a situation where the balloon expulsion is present, the anal contraction may be present or absent, the rectal pressure generation may be normal or poor. This is normal expulsion with abnormal manometric pattern of recto-anal incoordination. And you might have a situation where the balloon expulsion is absent, the anal contraction is present, the rectal pressure generation is normal. This has been labeled as abnormal expulsion with normal manometric pattern of recto-anal coordination. So basically, you could use manometry for several situations, and the various manometry graphs could be used for diagnosing various disorders. There is also an evolution of a 3D high resolution manometry, which could be especially useful when the patients have to learn, especially when they are involved in biofeedback, because it is much easier to understand this ways. So anorectal manometry is an excellent test to make a functional assessment of the anorectal apparatus. It is safe, easy to perform with very good patient acceptability. There is a proven utility of ARM in chronic constipation, especially in dyssynergia, fecal incontinence and biofeedback. It might also be useful in Hirschsprung disease, anorectal pain, OSC, etc. Thank you so much.
Thank you, Dr. Shrihari.